Hello, this is Dr. Ford Brewer with state-of-the-art preventive medicine, heart attack, cancer, and stroke prevention. Today we're going to talk about removal of plaque from artery walls. And everybody knows you can't do that, right? Well, that's not right. Actually, I'm a poster boy for getting plaque out of my artery walls. I'm going to show you my CIMT results from 2 years ago. As you see here, that's my CIMT. It was done in February of 2015. I was 57 and I had a plaque here and a discrete plaque there. Well, that wasn't good news. If you look at my artery age, it was estimated at 73. Here are the normograms for the predictable amount of thickness that you expect to see for males and females, and there's mine. So again, I was not a happy camper. That's an emotional event whenever a patient sees a plaque in their artery wall. For me, that was a surprise too. I expected to have crystal clean arteries. I'd always been the poster boy for good heart attack and stroke lifestyle. Nobody expected me to have that. I started off as an ER doc very early, in my early 20s. Got very frustrated in seeing too many early heart attacks. Went to Johns Hopkins to learn prevention and ended up running the program in prevention. I've taught a couple of the past presidents of the American College of Preventive Medicine. And so I know prevention, and I've always basically practiced it. Good diet, good lifestyle, good exercise, all according, plant-based diet, all according to the standard recommendations. Now, what I'm getting ready to show you is plaque, so you can understand what that is. You can see that in a couple of my other videos as well. To understand plaque, you need to understand the artery. There are two layers of the artery that we need to look at. One is the intima layer, the other is the medial layer. Normally, LDL, the small dense LDL particles, can go through this intima layer, and then when they do, they'll go straight on through the medial layer. In arteries that have inflammation, they lose the ability to pass through this medial layer. That's research, by the way, that's only just a couple of months old. It was done by a mentor and friend, Brad Bale, along with Amy Donine and David Vigorist. So what you're looking for here in a CIMT is the carotid artery intima media thickness test. So again, that's where you're going to get plaque laid down. Let's look at it in terms of plaque progression. This end of the picture is a normal, healthy artery with very little plaque. As you see it progress, you get more and more plaque. One of the things you may notice is that the flow is not compromised until there is a way deep level of plaque here. So that's why flow studies like angiograms and stress tests are way too late. They don't really look at doing any kind of intervention, and they're intervention or surgery focused. And they don't look at that until you get a 50% occlusion. As you can see, this is with this kind of plaque, you still have very little occlusion. So we're saying, wait, move back up here and start thinking about the determinants, the things that make your plaques inflamed, the things that cause deposition of plaque. Here's a couple of views from patients that had heart attacks. This is the intima layer, that narrow layer, the lining. This is the media layer. So everything in between those two is plaque. So that's what they were measuring with me. They were measuring the thickness and saying, look, even though you're 72 years old, you've got enough plaque here to where you fit the normogram or the average of a 73-year-old. This shows another thing too. It shows inflamed plaque. What is inflammation of plaque? Inflammation of plaque is where your immune system attacks it. White cells go in, or immune cells go in with antibodies. They release enzymes. We can actually measure a couple of those enzymes, myeloperoxidase and plaque-2, in blood tests. This is what causes a heart attack, not this. This is a waxy, stable substance. This is a liquid. And as you see from here, the liquid, when they dried this sample for the microscope, retracted away from the slide. You can also see there is very little standing between the artery or the blood and that hot plaque. And here's why that's a problem. Hot liquid plaque, when it touches blood, will cause a clot. And it's not regular plaque that causes a heart attack, it's the clot. Well over 90% of the cases. And the clot, again, comes from liquid plaque that has gotten out and touched the blood. That's exactly what happened with this patient. As you see, this is the intima layer. The media layer's out here. This is plaque. And the intima has a few cracks in it. We actually look at that when we're looking for microalbumin creatinine ratio. That's one of our tests for inflammation. I'll talk about that in another video. But you see here, this hot liquid plaque has leaked into the bloodstream, and this is a clot. The majority of this clot broke off, went up to the heart, and caused a heart attack and killed this patient. This clot down in here shows evidence that the blood actually seeped through the cracks in the intima and formed a clot inside that area, inside the wall as well. So, I'm still standing. I didn't have that happen. But what did I do about it? Well, obviously there was not a whole lot that I could do for my plaque and my deposition of 73 years worth of deposition of LDL in my artery wall in terms of lifestyle, because my lifestyle was pretty good. I pretty soon though began to realize that if I had not had a good lifestyle, I very well could have had an event, and all the bad things that go along with having a cardiovascular event. Now, I did have some other things, and you might be guessing genetics. Yes, I did. I had some genetic challenges. I had 9p21. 9 stands for the number of the chromosome. You know, we've got 23 chromosomes in there, 23 pairs. 9 has a section on it called P21, which has a lot of heart attack gene problems. And in fact, if you look at Brad and Amy's book, Beat the Heart Attack Gene, that's the one they're talking about, 9p21. I also have 4q25. That one, again, on the 4th chromosome, is really called an atrial fib gene. My mother has atrial fib. I have atrial fib. We have some predisposition for that with that genetics. It's not all just atrial fib, though. Current evidence is beginning to indicate that it also has some risk associated with heart attack and stroke as well. Fortunately for me, I had HAP11, haptoglobin 11. And again, I have a series of genetics on cardiovascular, or a series of videos on cardiovascular genetics. We can talk about those later. What else did I have? ApoE33, so not a lot of risk associated with ApoE4. Didn't have that allele or that gene. Did have high blood pressure. And as I've mentioned a couple of times before, I had insulin resistance. One of the major associations with 9p21, by the way, is diabetes. So that could have, I had a genetic predisposition for both diabetes and heart attack and stroke. So what did I do? I did do a couple of lifestyle things. I did a little tune-up. I started eating salmon every day. I added to get omega-3s. I added niacin, which is a supplement, which improves HDL, decreases LDL, and decreases triglycerides. Niacin's an over-the-counter. You get up to about 2 grams, and it is the only thing that we have so far that has such a widespread effect on our cholesterol values. Was it the niacin? I don't think so. Well, it could have been. I think the niacin helped, but I don't think so. There were a couple of other medication modifications I made. One was Ramipril. I had high blood pressure. I was on an ARB. I switched to an ACE inhibitor. We've mentioned that before. We'll mention that again in other videos. ACE inhibitors, like statins, do more than what they're prescribed for. ACE inhibitors are prescribed for high blood pressure. They actually decrease inflammation, that process that causes arteries to lay down plaque. Likewise with statins, and I think that's where I made the biggest change. I had been avoiding taking statins, like most of my patients, because of the side effects that I'd heard of. I went ahead, bit the bullet, and took Crestor. Took a very low dose of Crestor, 5 milligrams. I could take a lower dose. The lower doses impact inflammation. They don't impact diabetes at the lower doses. And I think that's what made the difference. Oh, by the way, what was the difference? A year ago, my plaque age, my artery age was 59. And a few months ago, my artery age was 52. So, you can't reverse plaque, right? I don't believe that. Thank you.